you very much for coming on a Friday to our maybe last THETA round of the season. There might be one extra special round in 2 weeks, but we're not sure about it yet, so we don't advertise it. So we're very happy to have Eva with us. Eva is an assistant professor at Western University. She's also working at the University Hospital in London as a health economist, and Eva has come in some ways as in her own words, she came home today because she did her PhD here at the Perry Crown some years ago, and maybe 3 floors up. So it's great for us to have her, and I hope it's great for her to be back. And she's going to be giving a talk on the disinvestment possibilities and how can we implement disinvestment in a hospital-based setting. And so we are very, very happy to have you, and we're going to take the way after we introduce ourselves to you. And I'm going to start. I'm Petros Peklivanoglu. I'm a scientist at Schulich. And our moderators for the webinar session are?
I'm Joanna Bielewski. I'm a research librarian at THETA and also a webinar moderator, #1.
Hi, I'm Wilson Wright, IT architect at THETA.
Wendy Younger, Director of Technology Assessment at THETA.
Kate Smolma, Wendy, Project Manager.
Tomorrow, Younger.
Maybe what?
Josephine Wong, Research Associate, THETA.
Austin, I'm a PhD student at HPME.
I'm Aisha, PhD student at Pharmacy.
I'm Yeva, Research Associate at THETA.
Ben Chung, Research Associate, THETA.
Basim Hamandi, Drug Information Pharmacist at UHN, also PhD student at Pharmacy.
Lisa Masucci, Health Economist at St. Michael's Hospital. I'm Santana Diaz. I'm a master's student at IMS.
Oh, I'm Karen, Emerged Research Associate. Known Ava for a while.
Hi, I'm Neva. I'm a research associate here and a PhD student at HPME.
Valeria, Associate Director of THETA and Assistant Professor at HPME.
Hi, I'm Manuel Young, Health Economist at Health Quality Ontario. Teresa Chori, PhD student at Pharmacy.
Of course, sorry, PhD student, Health Services Research at HPME.
I'm Lucinda Raman at Associate at HPME.
I'm George Tomlinson. Maybe we've met before.
Maybe. You too, Tom. Thank you.
And I think we have 14 other people online that are listening. So take it away. And as we discussed before, you feel free to ask questions during the presentation.
Okay, thank you very much. Thank you for your introduction, kind introduction, Petros. And yes, it is very much coming home. My office was on 13 Eaton North when I did my PhD studies. And I see a lot of familiar faces. So thanks for the opportunity to present here at THETA Collaborative. And I always think of THETA fondly for many reasons. And one of the reasons I like to tune into the webinars occasionally is to just keep abreast of advancements and methods. This is not that kind of a talk today. It's a little bit different, you'll see. So my topic is how can economic evaluation inform cost reduction and disinvestment in the hospital setting? And my goal today is not necessarily to answer that question in totality, but to show an example and then from that start a discussion. And seeing Wendy here and having chatted with her, she very much understands the situation of hospital-based technology assessment, and for others that maybe some of it may be familiar to you, for some new. So, to a point. Sorry?
Sorry, perhaps.
Oh, okay. Oh. All right, let's use it. Sorry, no problem. There we go. So I have no conflict to declare. So today, I'm going to present a little bit about the policy context of what is happening in hospitals with respect to cost-cutting initiatives and why they have become recently even more important than in the past. I'm going to go through an example where we apply economic evaluation methods to a cost reduction initiative to address trade redundancy, and I'll explain what all that means. We'll go through that study, the background method, results and limitations, and then hope we can have a discussion about the opportunities and challenges for conducting economic evaluation to inform this investment and cost reduction decision making. So first, policy context. So here I have an infographic from the CIHI, Canadian Institute of Health Information, National Health Expenditures Report, and it shows a pie chart comparing 1975 to 2014 in terms of where health expenditures go. And hospitals have been, over these 40 years, the largest category of health expenditures, more than physicians and drugs. But that proportion has been decreasing steadily time. This shows a growth rate over time. And so the changes, the drug spending as a category of expenditures have actually been decreasing. Physician expenditures increasing. Basically, the rate of change in hospital expenditures has been lower than that of drug expenditures. And so potential concern, even though we have a trend over time of lowering proportion of the cost curve is not decreasing as fast. This shows very similar information, change in time in the proportion of spending allocated to hospitals and the rate of change, and how that the rate of increase has been slowing, but not as fast as with drugs. So what are the drivers of hospital costs? And CIHI has a somewhat dated report, 2011 report, that goes through all of these in depth if you're interested in following up further. But essentially, the hospital cost drivers include inflation and compensation of personnel. Personnel account for, I think it's roughly 60% of the cost of hospitals. Population growth and aging, that does account for some of the increases in hospital costs. Thus far, not a lot, but with the horizon of the aging Canadian population, expected to increase. Technology and innovation factors, new technologies, costly technologies like MRIs, etc., but also the diffusion of technologies into the hospital setting. Unlike drug policy decision making in Canada, hospital policy doesn't have, shall we say, a framework for managing and evaluating new technologies, new drugs, new devices, new techniques, surgical techniques, new ways of managing and organizing care. It's not a standard process. There are very few health technology assessment agencies based in hospitals, and the decision-making is a bit more ad hoc, even within drug therapeutic communities within hospitals. And then utilization effects. So with a shortening length of stay, moving procedures and treatments that used to be done on an inpatient basis to day procedures or long-stay inpatient day procedures, that means that the acuity of individuals in hospitals is higher and increasing with time, and so that's driving the cost effects. This is a quote from a qualitative study reporting on hospital-based technology assessment units. And this quote summarizes a lot of what HTA units experience. Technologies for which a request for evaluation is made are often already implemented in hospitals. In the case of such disinvestment decisions, the HTA units have to play a support role with limited power to influence clinicians' behaviors that are already well entrenched. And so this quote summarizes a few key messages. that for those few HCA units in Canada, and in this report, Marie-Pierre Gagnon speaks with and I itemizes all of the HCA units that were in existence at that time in 2011, and essentially summarizes key points. That HCA in hospitals typically related to disinvestment. There's no controlled kind of investment process where economic evaluation can be informed with HCA, including economic evaluation, and that there are stakeholder considerations that are very important, and that there's limited power to identify opportunities for investment or disinvestment, and limited power once they have been appraised to influence decision making. So there are a lot of challenges. So what are these opportunities? Well, just trying to summarize here what I mean by cost reduction in disinvestment: discontinue ineffective and harmful technologies. Those would be sort of the clear wins. We know it doesn't work, or we know that it's harmful. But then there's the lack of clarity around effectiveness that we would all be familiar with for any type of health-related question. Within hospitals, sort of malfunctioning medical device incidents, these types of opportunities, which are maybe more along the lines of course, of devices, but those types of opportunities exist. Decrease overuse of health technologies and improve appropriateness. So that's in the absence of a clear win, where something is clearly harmful or clearly ineffective, where there's uncertainty or where there are subgroups that may benefit, to try to target and improve appropriateness of care. Manage care with fewer and lower cost resources. And so the example I'll show you today, I think, falls into that category. And then decrease aggressive end-of-life care, which is another area of opportunity that I know less about and I'm not directly involved in, but I think for those that are interested in palliative care research or end-of-life decision-making, the hospital is also a setting where that would be important. So into that milieu of decreasing and targeting hospitals as a large category of health expenditures comes the very recent policy development in Ontario of the health system funding reform. So quality, as part of health system funding reform has many components to it, but the one that I want to highlight that in particular has impacted the London hospitals is the quality-based procedures. So these are specific groups of patient services that the Ministry of Health had highlighted, Ontario Ministry of Health has highlighted. And the goal is to share best practices that will allow the system to achieve better quality and system efficiencies. The quality-based procedures are listed here. So these have been rolled out slowly, beginning in 2013. I think the cataract day surgery may have been one of the first, but essentially the ministry undertook a process with each of these to do a comprehensive evidence review, define what are the best practices for these targeted procedures, produce a quality-based procedure handbook that is intended to be a practice guideline for those particular procedures at Ontario hospitals. The other aspect of the QBP funding formula, though, is that it's designed to, for those QBP procedures that have been laid out, incentivize efficiency. And by that process, there is a way of allocating funds to the hospitals for each procedure that is based on the average cost in the province, essentially. So for those at the funding is provided roughly at the 60th percentile. So they look at the cost variation across the province, fund for each procedure at the 60th percentile of the cost, with the goal of incentivizing efficiency. Well, of course, in that process, there are winners, there will be winners and losers. For a variety of reasons, London Hospitals has been one of those losers, unfortunately. So a very hot political touchstone issue, which is extremely important,
is for hip and knee replacement. So London area patients were waiting twice as long as in the Toronto area. Yeah, I'm not here to start a fight. I'm just highlighting the challenges. And essentially, for 2 years now, the London hospitals have shut down their operating rooms in the last 3 months of the fiscal years, so from January to March of the calendar year, and they take very long Christmas breaks. The reason being because with the new QP formula allocation model, they're not receiving sufficient funds to perform those quality-based procedures. So hip and knee are quality-based procedures. Why is that? In part, they had some historical challenges with documenting their case mix, and so that might be the challenge. And it's a big fight between the coders and the physicians. The coders, the people who abstract the information from the medical charts, enter it into the CIHI discharge abstract database. That's their information used by CIHI to determine the case mix. The coders indicate that the physicians weren't documenting acuity. The physicians, say that the coders weren't extracting it properly. But so the historical challenges were that their patients looked healthier than they were, looked healthier on paper than they were in actuality. And so with this funding formula, it was just the worst timing for them. And so they didn't receive sufficient funds. And then regardless of HBAM, the new health-based allocation model, the funding is based on your historical cost, and as a result, that can just follow forward. So this is kind of right in the midst of when I arrived, and so the frenzy about cost reduction and disinvestment was even more heightened than usual. Okay, so I'm just going to present one example of economic evaluation we've done pertinent to this, which was, motivated by this cost-cutting urgency. So a little bit about surgical tray redundancy. Surgical tray redundancy occurs when surgical trays have instruments on them that are repeatedly unused. And the consequences of that are that there are necessary procurement costs, high personnel costs, because personnel are required to decontaminate and process these surgical trays. Nurses have occupational hazards because they're lifting trays that are heavy and they could actually probably be lighter. And then slower operating room throughput. And so this project arose out of the otolaryngology department, where one of the specialists there just really took a step back and said, we don't use all of the instruments on the surgical trays when we do operations, every time we do operations. What's the rate of that use? And can we, find an opportunity to reduce costs here? So these are just the processing steps for surgical trays. They go through cleaning and decontamination, and that's essentially a manual process. So after a surgical tray comes back from the operating room, there are sterile processing personnel that dump them all the instruments out and manually clean them with water and detergent, and inspect them and remove debris, etc. Ensure that they are functioning. Throw them out if they're not. Then they reassemble the trays, and so the trays are assembled in a specific way for each operation. And so in the sterile processing room, there will be pictures of how the trays should look, and the personnel reassemble them, and then sterilize them. Then that's done in a machine, store them, and deliver them for the next operative procedure. So the project we present today, our objectives were to review the instruments on the surgical trays for 5 commonly performed otolaryngology procedures, which are septoplasty, tonsillectomy, skin cancer excision, endoscopic sinus surgery, and septorhinoplasty. To propose reduced surgical trays based on the findings of the review, and to perform an economic evaluation comparing the cost of surgical trays with redundant instruments to the reduced surgical trays. So I will note that this economic evaluation was done at the stage of proposing the reduced trays, and they are still trying to implement them. So again, it's theoretical, but we shall talk a little bit about that. Okay. So for the tray utilization review, 226 instrument trays were observed through the surgical cases of 4 academic surgeons at St. Joseph's Healthcare in London, Ontario. These were examined over 3 months. So at the end of each surgery, they would review the list and identify the instruments that were used. So they reviewed them, and of course, the complementary would be they could figure out which weren't used. They proposed reduced trays consisting of instruments that were used at least 1 out of every 5 times, 20% of the time, but also incorporated feedback from other surgeons to ensure satisfaction. And so if something was proposed to be removed where they felt, oh no, I know it was used infrequently, but that would be important and maybe used 1 out of 10 times, it should remain on the tray, then they did put it back. So it was it wasn't just strictly based on frequency of utilization. So for the economic evaluation, we did a cost analysis, 2013 Canadian dollars, from the hospital perspective over 1 year. And it's a model-based analysis, a very complicated model, I'm just kidding. Sources of data, we had hospital data and data from the literature. And we also did an additional scenario analysis where we incorporated indirect cost savings on utilities, reagents, quality checks, and equipment maintenance. So here's a very complicated model. The tray cost is built up from the instrument level. And so, based on the number of procedures at the hospital and the number of instruments for each procedure, we could calculate the cost based on the time of the personnel to decontaminate the instruments in the tray and then to pack them during reassembly of the trays. And then we also incorporated a depreciation cost. It wasn't directly estimated from the hospital, but we incorporated a depreciation cost for the instruments. And then this is, so I forgot to refer back to the scenario analysis. So in the base case, we did not incorporate any savings from reagents, utilities, from, because with simply 5 procedures, we wouldn't expect those to be very significant. But it was just, we incorporated that scenario analysis to get at what if this strategy was implemented more broadly, perhaps across all of hospital procedures, so then we could start to see potential savings from reagents and stuff. So to calculate the per instrument assembly time, this is something where there is actually fairly good routinely collected data. So for those who use case cost data, the case costing department uses the tray assembly time in order to allocate the cost of the sterile processing department to the different departments. And so they have very good information on how much time each person in the sterile department spends assembling otolaryngology trays, because that's how they allocate the cost to otolaryngology. So we had that data. Unfortunately, they don't calculate the decontamination time, but as you can understand, that's something that's done in bulk. So it doesn't vary by department, at least not very much. Trays come down and they just dump them all in and clean them. But the assembly is something that's easy to allocate to the department. So we had from them the mean packing time per tray across all the otolaryngology procedures, 173 trays, 9,000 plus assemblies. We chose those trays with at least 10 instruments and 10 assemblies to give us a better approximation to the 5 procedures that we were looking at. We divided, so unfortunately, but it's probably not all that big a challenge. We only had the mean time for each tray. So we really only have 39 estimates of mean time, even though it represented a lot of assemblies. And so we divided the total number of instruments per tray by the average tray assembly time to calculate a mean per instrument packing time of 17.5 seconds. So as you saw with the model, it's important to understand how much time it takes to pack one instrument. So that's the other model parameters. The first, the per instrument packing time, I just explained. Per instrument decontamination time, as I mentioned, we have no measure of that. I suppose we could have measured it, but you know, the payoff versus the value of the information kind of plays into it. And also, people don't like you standing around with stopwatches while they work, right? So it's probably going to be a little bit sticky to get it. So we had a fairly good estimate from the literature where they had broken down the times for each of these steps. So the per instrument decontamination time we took from another publication. We got the per second cost of personnel time, per instrument cost of depreciation, again, another publication, and per instrument indirect cost, also obtained from another publication. That's for the scenario analysis, not in the sort of base case. So, okay, so this is the tray utilization review that I was talking about. The reason there are more than 5 trays is that across the 5 procedures, some of them have more than one tray. All right, so the number of trays, you know, for some of them, like the spheroid, and there weren't that many observed, but, you know, for sinus and septoplasty, there are quite a few. The number of instruments is displayed there, and the mean utilization rate. So basically, for some of these, only, you know, 20% of the instruments on the trays were used. And in just sort of informally talking with people about this, they suspect this is the case at other hospitals, and there's quite a bit of, not quite a bit, those that have studied this in the literature have found similar results. So there are quite a few unused instruments on the surgical trays. Okay, so these are the volumes at LHSC for these procedures, London Health Sciences Center. So ranging from 197 to 500 plus. The number of instruments on extant trays, so the number of instruments on the trays currently, and that's, you know, if there are 2 or 3 trays, they're all combined into one. And the number of instruments on the proposed trays, so the reduced trays that were chosen first as a first pass by looking at those that were used at least once every 5 times, and then also ensuring that other, you know, relatively frequently used instruments were on there. So in some cases, a fairly large reduction of 64%. Oh, yeah. How do I go backwards with the mouse? Or can you do it for me? Yeah. Sure.
If it says only, let's say, 20% is used, it assumes every time it's the same thing. It's the same type of instruments are used and the same are not used. Is the case. Let's say you have 5 instruments, but each time you use 2 of them, but each time it's different too. It's not the same.
Right. So the mean utilization rate was across the observation period.
So across the observation period, mean utilization rate, and then the way that they selected them was on, you know, being used 20% of the time for those that they had, I think, enough.
It is per instrument. It is a bit hard to listen per tray. Because you have per procedure, right? Per procedure you have different steps.
Right. So this,
what I'm presenting here is just the, you know, sort of the model input, like the number of instruments on the extant trays, what the number of instruments they proposed to have on the reduced trays. Yeah. The previous slide was the result of the utilization review, or I think it was previous. I can't remember now. Okay, so this is the % reduction. Yes, George?
What would happen if someone needed an instrument that wasn't on the, maybe we'll get into that, but
right.
Was that built into your model? They could actually get it?
So at the stage that
I did this analysis, they had not yet specified, so they were planning to have a separate tray of extras, right? But hadn't yet specified what would be on it and how much. So that's a limitation of this study. And, you know, I think they're still working through that. And that once they get around to implementing, there will probably be an extra tray. And so that's definitely a limitation that the processing of that hasn't been incorporated, but it wasn't really clear what that would look like. So yeah, it's a good question. It's an important issue. Okay, results. So the cost of redundant trays
of the tray for the entire year for those 5 procedures,
$21,800. Reduced trays, $8,800, and estimated cost saving of roughly $13,000. So certainly, you know, huge savings, and
we're going to save the healthcare system with this type of approach.
No, I'm just being sarcastic. Sorry. So, we did do sensitivity analysis, only one-way sensitivity analysis, but varying over a pretty large plausible range for each of these. So for the decontamination time, the instrument packing time, cost of personnel, depreciation, for those first 4, you know, this does seem to be a key variable in terms of how large it varies as a result of the per instrument packing time. So it's good that we did have hospital data on that. Tray reduction. So the reviewers for this paper asked about variation in tray reduction, and then also surgical volume, and so we added that in. And so surgical volume obviously would be a very big driver of cost. So for those centers that are larger than ours or smaller. So for this, we just looked at surgical volume 1/4 our size and 4 times our volume, and then 25% reduction versus not as much, like 10% higher. So this is a scenario analysis that I mentioned where with 5 procedures, you wouldn't expect savings from utilities, reagents, inspection time and checks and that sort of thing to be significant. And so we wouldn't put that into the base case, but to sort of get at the idea, what if this were implemented more broadly? What would you multiply by would be probably the scenario analysis. So the cost of redundant trays was $48,800, and reduced trays $19,700 roughly, with an estimated cost saving of $29,000. And so that would give a better idea if you were implementing this as a strategy, say across all of the surgical procedures and not just in otolaryngology, but across the entire hospital, because you would need to purchase fewer instruments, and then you wouldn't be paying this opportunity cost, I guess, for those instruments that are in the tray and unused, because you purchase them, they go through the processing, and that contributes to their wear and tear, and they cost money to depreciate.
Sure. Most of the savings are accrued through reduced labor time, right? It's the prep time or the packaging time, assembly time. Mm-hmm. So that's part of the salary of an FTE. So, I mean, ultimately, that you might be able to reduce your labor pool if this was scaled up to other procedures. So those individuals may be involved in other types of packaging or assembly. I mean, it creates other problems if you're reducing personnel, but I'm just wondering what the breakdown is in terms of the kinds of components where the savings are realized.
Where the savings, yeah, that would be a good, could you back up?
Oh, but it was in your original.
No, I didn't provide a breakdown of where the savings are, so that would be a good one to do, yeah. This is going to give us some idea. No, this is fine. Yeah. So with it, so in terms of the cost of the personnel allocated to the instruments, I don't think there's as much there, but that's just because the range of the salaries is very narrow, if you recall back. It is a very relevant strategy, reducing personnel, because both St. Joseph's Hospital and London Health Sciences Centre had to dip into their reserves, and one of the strategies they used was to reduce the time of employees. And they tried their best not to fire anybody, but to reduce the time. So it is actually quite a relevant approach. But at least given their salaries and given the way I've structured this, which we talk about a little bit later, at the per instrument level, the savings will mostly be driven by really like how long it would take to assemble these trays, which has a wide variation.
So if this is implemented, could they discover they don't need all these instruments that they purchased, so you could save money on the cost of instrument purchasing in the future as well?
Yeah, so that was what I intended to incorporate with the depreciation cost, sort of as a single way to represent that in this simple model. Because once you buy the instrument, it depreciates faster, so there's a, but it is a very indirect way of getting around future savings on purchasing. Absolutely, because the model is constructed around the instrument, but that's a challenge.
Are
it is not captured.
Are the instruments themselves expensive to purchase?
It depends. The wide range, and so that's the depreciation cost, the cost of purchasing, all those sorts of things are something we can do a better job of estimating, right? I think that I currently felt, for the amount of work of dealing with the procurement department and understanding how much they purchase across the hospital or even for otolaryngology, how frequently, that didn't seem to be worth, the effort of this kind of at this stage. But if you think it's a worthwhile path of research, I can certainly invest the time. Yeah, the other question?
Yeah, I was just wondering, with the instruments that got out of the tray,
yeah.
Out of the instruments, do they never ever need them? Or like if they need them, like
right.
One
yeah.
Or could they do it with the other instruments on the tray, or are they gonna struggle and just like this big emergency and like a big cost because it's not there?
Right. So it is a concern, and I think that's probably one of the concerns preventing them from actually implementing this. But I do think that they intend to eventually. Some of the excess comes just from legacy instruments just being in the tray. So a surgeon that was at the hospital 5 years ago requested a particular instrument. I like that one from that manufacturer. They purchased it. Like I said, there's really not much control of any diffusion of technology in the hospital. They purchased it. The physician could be long gone. The physician could be here, could be in Ottawa, but they don't go through reviews, really. I mean, and that might just really be the most important message is to regularly review these, and it's surprising they don't. So some of the excess comes from that. So I think for that kind of excess, which is just a matter of really something that seems like common sense, review the instruments, don't just have automatic standing orders to repurchase them when the CPD personnel throws it in the trash bin or wherever they throw it. Don't just automatically repurchase, have reviews. So that, but for that kind of the gray zone, those that are used infrequently enough to not make it in, but might be used at some time, they were thinking of having an extra tray, which would by definition not be processed as frequently, but would remain in the room. But that raised also issues, right, for the OR manager to sort of now keep track of an extra tray. Like, I mean, keeping track of the trays you need for the procedure, what's on the list for every procedure, easy enough. It's like a sort of a new process now to make sure this extra tray is always there and that you're not scrambling to send someone to get it. So, yeah.
So usually what we tend to hear with this investment is that it happens more ad hoc. Yeah. And I'm wondering whether the same happens here. Like, what if there is an instrument that is not being used anymore, and suddenly can someone take it off the list, or it has to be like, is it like a formal procedure where you have to remove things from the list, or they are happening naturally?
So it's happening naturally. It's not a formal procedure. There is no formal procedure, and maybe that's just what they need to do. So it isn't formal.
The counterfunction might be that not that the tray stays as is, but the tray is slow. It's a dynamic thing, and things are being forced out over time.
Right. So rather than reduce it all at once through this entire process and say, well, we're cutting it down, implement a process where whenever there's the need to purchase or renew an instrument, that there's a review process. Do we really need it? Yeah. So these are the challenges, right? Okay. So this, I went to the scenario analysis. Okay. So there are lots of limitations. I mean, so model-based estimates of cost savings. Yeah.
Sorry,
I'm
just struggling, like, to kind of think through what does it mean, the cost savings, like, calculate, like, what's the, the time frame, or like, how much would a hospital save over a whole year, or?
So this was a 1-year time frame that we took. So we looked at the number of those 5 procedures that they did in a year. And so it was all based on 5 procedures over 1 year. And
so in the results, so it, now I forgot what the cost savings was.
Just maybe back one, or back one from that.
Okay.
So it's 13,000 over whole entire year?
Yes.
For one hospital?
One hospital, 5 trays, which is a drop in the bucket.
Yeah.
Yeah, it's kind of so what, right?
Yeah.
But it is 5 procedures, so it would be a little bit larger, I guess, if it were implemented more broadly, right? And it's not all the procedures in otolaryngology, and it's not all procedures in hospital. Okay, so model-based estimates of cost savings based on retrospective data. Now, for this room, there are many modelers and that kind of thing, but I think we would all prefer probably maybe to implement prospectively and also to understand how this would work, right, and how it would impact the operative setting. As I mentioned, cost due to processing an extras tray was not included because it was, a bit nebulous at that time. Of course, this type of approach would require and rest on prospective validation and implementation of tray optimization, whether that would be this proposed reduction or just simply having more processes about reviewing instruments and decision-making around that.
We certainly have not incorporated in any way potential adverse consequences of the need to retrieve instruments that are not on the trays. And this is a, per instrument model, right? So that is a little bit challenging to incorporate in that same framework. Of course, we haven't looked at impact on operating room processes. Not that it couldn't be looked at, but that's, I think, is different types of modeling, different skill set. There might be faster operating room setup or cleanup, easier retrieval of instruments during operations potentially, with fewer to look through and to identify what instrument is needed. And there has been a study that found with reducing trays by 70% that the setup time for surgery decreased significantly. And so there are possible savings. Of course, you wouldn't represent that in this framework because it's built up from instrument level. It's a utilization effect, right? And might actually raise costs if they can do more surgical procedures in a short time frame. So summary, our cost analysis suggests modest cost savings, right, can be achieved. Sensitivity analysis suggests that they range, this is based on the lowest and highest from the one-way sensitivity. Per instrument, packing time during assembly is a key cost driver. The implications, while modest, the cost impact would be greater for broader range, and so this might be an important approach. So to touch a little bit on the question that I posed in my title, and hopefully, start a discussion about that. Well, how can economic evaluation inform cost reduction and disinvestment in the hospital setting? I think to some extent, for those that understand economic evaluation, that is a pretty, an easy question to answer. It can help to quantify expected cost savings and health consequences of cost reduction and disinvestment opportunities. We have excellent ways to characterize uncertainty and estimate the value of further research. We could also potentially identify opportunities for disinvestment and cost reduction, perhaps facilitate a more structured process in hospitals to, access the information available in literature about what works and propose opportunities, or to bring information about what's effective and not effective, rather than have it all be driven by clinicians. However, that's a stretch right now of being kind of drivers and leaders in identifying opportunities. So that's, so there are a lot of challenges, right? The methods for disinvestment and cost reduction, and particularly in hospital, are underdeveloped, particularly to identify and also to appraise technology. So as I've already mentioned, in hospitals, technology is diffused into practice, and there's no framework for using economic evaluation to inform this investment, disinvestment, or cost reduction decision making. Even on drug and therapeutic committees in hospitals, it's not formal to use economic evaluation. Stakeholders play a very important role. It's already talked about clinicians, patients, manufacturers. Without diffusion barriers, I guess, the manufacturers play even a more important role in the hospital setting. Patients as well. Donors, I'd like to highlight here too. For instance, at LHSC, there were donors who financed the purchasing of robotic surgical arms, where the evidence is actually quite unclear except for specific clinical applications, potentially with urology. But apart from that, the evidence is very unclear on the benefit. But if it costs roughly $1 million to buy the robot, the donor makes that initial investment, but it has implications on space, because these take up more more space, and have fewer operating rooms, essentially. Has implications on the skill set of the clinicians at that institution. So they all drive this diffusion and technology challenge. The funding formula, so this is an interesting one. The funding formula, it creates an incentive to reduce costs, but only so much, right? So if the otolaryngology department implements this and reduces costs, then, we think back to our central processing personnel that has to clock in when they're assembling an otolaryngology tray, and they get it takes much faster for them to build that tray, and then they are less costly to the hospital, and that means that next year's kind of funding allocation means they will get less. So the incentives, and this is something that's common and a common challenge across policy, not just in healthcare, but this challenge of, you've got to spend to remain funded, There's only so much incentive to reduce costs, and that also would potentially have a level. So lack of evidence and uncertainty, I think that's particularly challenging, especially with disinvestment. I didn't go into a disinvestment example, but especially with disinvestment, the evidence, you might argue that people have a higher evidence requirement for taking some. Acuity versus utility, that's just my way of saying it's challenging to think of quality of life in the hospital setting when people are undergoing procedures and at high acuity. Perspective, the hospital perspective is most important to the hospital, but economic evaluation frameworks certainly highlight the importance of societal perspective. And then this whole issue of utilization effects, right? So in the hospital, the implications on costs are not just to the person treated or to the instrument models, right? They are at the system level. So there are different tools required. So I think that was acknowledgement, startup funding from Department of Anesthesia. These are the institutions with which I am affiliated, and I would like to thank my co-authors. If you would like to look this up in more detail, the co-authors are listed there on these publications that describe more detail what I just talked about. There we go. Thank you.
We have 5 minutes maybe for questions. And
yeah, I mean, the point you made about the budget is really important. There's really no incentive to identify inefficiencies or waste within the system, because if you have a surplus at the end of the year, your budget is reduced for the next year. So the greatest, I think, incentive to recognizing inefficiencies is if the current procedures has a deleterious effect on patient outcome. Mm-hmm. So if the waste or inefficiency leads to a prolonged, let's say, OR time, or a higher risk of complications, then the hospital will react. Right. And then they may change their practices. But otherwise, you're really pushing against this inertia of adding but not subtracting.
Yes. No, I completely agree that I don't have a solution to the challenges that funding formulas pose in creating incentives, but it is a big challenge, and whoever can solve it.
But you might be able to turn your OR over faster if there's fewer items on the tray, and even just a few minutes, you can do more procedures.
Absolutely, but that also increases cost in theory, because you can do, but let's say it's so significant that you can do more procedures in a day. That increases cost, and then as I've already shown you with certain procedures, they don't want to do more of them. They can't afford it.
More health you're producing more quality, you're producing more health benefits.
Oh yes, absolutely. And then I think that's a little bit of the hospital versus societal perspective. Okay. The hospital shuts down their operating room because they need to keep the entire operation running, and they can't allow the department, what is it called, that surgical department, to cause them to dip further into the reserve funds. It's not because they don't want to improve the quality of life of the people who are on wait lists for hip and knee replacements, for example, as an example. So it is a tension, right? The perspective and then the fund and how the funding formula plays into that. Really?
Just wondering about the role of cost effectiveness in this. I mean, I think it's a really nice example of how just the things that we do routinely, kind of low dollar items, sort of drive up costs. And I mean, I see that all the time. In our area, it's like blood tests. We do just $1 million low dollar CBCs, electrolytes, so things that indications that are not. So, two questions. How are your findings more generally more generally generalizable? Like, can you draw any inferences about your wisdom from surgical trays to operations of hospitals more generally? And then the second question is, like, do you really need a cost effectiveness to address this question? Wouldn't just sort of simple utilization reviews saying, like, let's just sort of look at routine blood ordering and see if we can kind of streamline that? I mean, I just wonder about the role of economic evaluation in that context.
Right. So I think for the first question about being generalizable, I think the short answer is yes, but it depends on each question. So as you were talking about with blood tests, I don't think I know enough about what drives test ordering to say how to address it, but I imagine that there might be a role for reviewing test ordering practices, and I mean, there's literature on that I'm not very familiar with, but reviewing test ordering practices, maybe audits and feedback about test ordering practices, but there probably are some areas that are analogous to the trade. Do you need cost effectiveness to do this? I think that on one hand, it just makes common sense. You probably, the trade reduction, reviewing, making sure that they're all being used, makes common sense. However, sometimes there's power in putting a dollar value on something and quantifying it in however imperfect way. So it has that value in informing decision and maybe spurring people to action. But when they see a low number, they get kind of really, you know, we need millions in savings, right? Well, not thousands, but there you go.
Thanks for that. I'm also wondering about some of the other benefits that maybe, you know, from a safety perspective, right? So you don't have that selection of instruments to potentially leave inside the patient at the end of the surgery.
Right.
And or talking about the nurses and their occupational safety.
Right.
So that potentially are other concerns. I'm coming from a drug world perspective.
Right.
So we're trying to standardize the selection of meds, the standardization of concentration, so that you know we can administer these in a safe manner. That's
right.
Those are some other things I think can be incorporated in this as well.
Right. No, I think you're absolutely right, and I don't know how to quantify all of those benefits, right? Certainly not in the framework that I presented, but you know, I think the operations researchers might have, you know, a better background to draw on and to look at system impacts of these types of interventions with the trays. And then I think with patient safety with respect to medication, there's a bit clearer because you're following the patient, and but it also can have system-wide impacts that are difficult to measure.
Can I ask something quick? What was the response of the hospital in your work?
So the response was positive, but I did have a conversation with the CEO of St. Joseph's Healthcare, one of the two hospital centers, and she said, yes, it was a nice analysis. Those cost savings are a little smaller than we're looking for, but it was a nice analysis. And it's not something where she just said, tomorrow we're going to do this. I think it's coming up from the department. Yeah.
All right. Help me thanking Ava.
Thank you.
Thank you for coming, and have a great long weekend.
Yes. Thank you.